So my name is Yoshinobu Onuma. I'm an interventional cardiologist, and currently I'm working in Ireland, Galway University Hospital and University of Galway. My specialty is the interventional cardiology, but I have a special interest in the BioResorbable Scaffold and other novel coronary artery devices. So the history of the development of BioResorbable Scaffold started a long time ago, like in 1980s, and first-in-man trial of the first device called illuminating started in 1999. After that, there was the drug-eluting, everolimus-eluting BioResorbable Scaffold was tested in human in 2005-2006. And it became somewhat popular mainly in Europe after receiving the CE mark in 2011 and up to 2016 that BioResorbable Scaffold device was used in the different indications. However, in 2017 there was some safety issue of the first generation BRS, so globally the usage was somewhat dropped. However, the new generation of the device is being developed and recently available. For example, Meril 100 has a thinner strut, and that new generation device potentially could address the issue we have seen in the first generation BioResorbable Scaffold. And so that's the concept of the metal Metal-less PCI is re-emerging. What is the concept of the metal-less PCI? So when you put the stent, the metallic small tube in the coronary artery to treat the narrowing or the occlusion of coronary artery disease, usually the metal stays in the coronary artery for life. So after the stenting, the remodeling of the vessel is somewhat prevented. There's also the limited reaction in response to the medication to modify the plaque. So once metallic stent was placed, it is caged and it's permanent, and we have seen that in the clinical trials in the long-term follow-up there was a steady increase of the very rate event, like 1 to 2% per year in that target region, which is potentially related to this metallic stent. So the BioResorbable Scaffold concept is that acutely it will function as like metal to scaffold the vessel wall to prevent the acute occlusion or to seal the acute dissection, and also the early negative remodeling is prevented 3 to 6 months, and later on the BioResorbable Scaffold is disappear gradually, and the later phase, very late phase, it will really free the vessel so that the vessel can remodel according to the physiological stimulus or even in response to the medication to regress the coronary plaque. So also it will also restore some vasomotion function of the physiological vasomotion of the vessel. So that's the concept of BioResorbable Scaffold, and that's kind of the concept of the metal-less PCI, so that in the first 3 to 6 months it works like metal, but it's gradually replaced by the biological materials, and eventually the vessel return to the normal physiological coronary artery. So this could be also achieved by the not only the BioResorbable Scaffold, but also for the drug-coated balloon, and recent emergence of this concept in usage of the drug-coated balloon technologies. There's many technologies are in development. There was a limitation of the first generation polymeric BioResorbable Scaffold. There was the safety issue of the very late scaffold thrombosis. So the first generation has a very thick strut, and it was somewhat challenging to embed this strut into the coronary arteries. So initially that creates some milieu for the thrombus, early phase with low shear stress behind the scaffold. And later on, when the scaffold loses these mechanical properties, then some of the strut, if it is not covered and encapsulated well into the vessel wall, it collapses into the lumen that creates some very late scaffold thrombosis. So that was a safety issue. How to prevent that? There was a couple of ways to prevent that. Of course, the one we could improve is the implantation technique so that the scaffold is well embedded. But what is also important is to make the scaffold itself thinner so that the operator can somewhat easily embed the scaffold and facilitate the vessel healing and encapsulation of the tissue, the scaffold by some tissue in later phase. So this could be achieved more easily when the scaffold was thinner and the surface area is smaller, and new devices such as Meril 100 has a thinner strut. So the first generation polymeric device such as Absorb has a 150, 160 micron strut thickness, but Meril 100 is the reduced almost 1/3 of the thickness, so it's 100 micron, and that must be facilitate the better embedment acutely and also the better healing encapsulation of the scaffold in later phase. So we hope that these new devices will address the safety issue which we observed in the first generation devices. Because of the difficulty of the embedment and the encapsulation of the device, probably this device is not for the all patient or lesion, because if the plug itself is very rigid, like it's calcified, then it may have it will pose a difficulty for the operator to embed the scaffold very well. So maybe the most appropriate patient or lesion would be the young patient, and also the plug is very soft, such as the vulnerable plug. So the concept of the vulnerable plug is that usually the plug becomes more lipid laden, and such plug could cause the thrombosis in the later phase. However, these plugs are somewhat soft, not really rigid, so it might be suitable for the scaffolding with this new generation device. So I would say it's, in my opinion, the young patient who will benefit from the disappearance of the scaffold, and also the somewhat soft and simple lesion, such as the vulnerable plug or some kind of the acute coronary syndrome plug, could be also potentially the target of this technology. There might be the one or two scenario I could think about. First is there was so much diabetic population in India. If you compare the Indian study to the European studies, we have seen that more diabetic patient, and for the young diabetic patient, for example, they might have not flow limiting, but some kind of the high risk plug, and some of the early study like combined OCT show that even the FFR is negative, there might be the high risk plug detected by OCT could cause further event in the future. So maybe this kind of device could be suitable for this type of the lesion, the high risk plug, vulnerable plug observed in the diabetic population. Of course, this needs to be tested in a clinical trial, and the benefits should be shown, and safety should be also shown. But potentially, those kind of the patient might be the good indication for this kind of the device, the PRS device. Yeah, the other component is somewhat, we have seen that in Asia, they might tend to appreciate their native body. For example, to avoid the permanent metallic implant might be for some patient maybe the psychologically or the culturally important, and if the patient prefer that kind of the therapy, I think also veritable scaffold could be the good option for this. The concept of the veritable scaffold is very intuitively good, because acutely it performs like a metal, but gradually it replaced by the native coronary arteries, and it will facilitate the future healing. Currently this device is not for all patients, and the new devices coming, such as the Meril 100 device, is really coming to the clinical scenario. I think we will soon have more evidence to support the usage of the second generation, new generation veritable scaffold, which will inform us more about when and what kind of the patient and how we should use this device.